Kongrenin öğleden sonraki oturumunu açıyoruz. Bugün çok güzel bir konuyla devam ediyoruz oturumumuza. Atipikus tedavisi ve tanısındaki zorluklar. Konuşmacımız Profesör Doktor Hermann Haller. Kendisi Hannover Üniversitesi'nde uluslararası birçok fiziki çalışmaya sahibi olmuş. Hipertansiyon, transplantasyon, böbrek yetmezliği, diyabet konularında birçok yayın olan bir araştırıcı. Bizi daha önce dinleme fırsatını bulmuştuk. Gerçekten çok bu konuda deneyimini paylaşmamızdan çok faydalanmıştık. Kendisini kürsüye davet ediyorum. Konusunu konuşmak üzere. Buyurun.
Oh, that's much better. Thank you. I'm sorry I cannot give my lecture in Turkish. I will not even try to do that, but I will try to go slowly through the slides and to make it more understandable. What you see here is a complicated disease, and especially the pictures in the middle is an illustration. It's a rare disease. It starts with a small thing, but then it becomes much more dangerous, sometimes unnoticed, but very often these patients then end up in our living room in the hospital. So the question is how to diagnose this disease early and how to deal with this patient. I personally consider this a disease for real doctors, because a lot of time we see patients and they are not complicated. But these patients are a challenge. And I would not be here if we would not have a treatment strategy. Rare diseases become only important for us really when we can do something about them and treat them. I have to show my affiliations and disclosures before I start. Normally, we show these slides only for about 5 seconds. There is actually an article published on how fast do speakers go through their affiliations and their honoraria. So the diagnosis of APPHUS, we have 4 major challenges. The clinical presentation, which is variable. It's difficult to think of the disease because it doesn't happen all the time, and the presentation, as I said, is variable. Secondly, the underlying molecular mechanism. That's complicated. We understand a lot about the disease, but it's not easy to understand. The condition is associated with other conditions, and that's also very challenging because I will describe pathophysiology, but then we are dealing with the complement system, and the complement system is involved in other diseases as well. So the question is, what is the relationship of complement activation with this specific disease, APPHUS? And then, the therapeutic strategy is also not easy. It's not like prescribing an easy drug. We have only one drug, but we have different strategies, so this has to be an individualized approach. Now let's start with APPHUS. The clinical signs and symptoms of thrombotic microangiopathies, TMAs, is, as the name says, thrombocytopenia. Mostly we are called when patients come in or when a patient develops a low platelet count. It's important to realize that the platelet count is not by itself important, but the fall. So if you fall from 350,000 to 80,000, that's about as bad as when you fall 100,000 from 130 to 30,000. And we have microangiopathic hemolysis. So a patient with a little bit of anemia and then schistocytes in the blood smear. And you already can see here that at least we have 2 different type of doctors. We have hematologists who are interested in the disease, and we have renal doctors, because mostly the patients also present with renal failure to some degree. And the worst cases, and this is why we're here, is when you have full failure of the renal function. But also other organs are involved. The central nervous system is involved, the lung can be involved, and I will finish with catastrophic cases where other organs are involved. And it's important for us, because normally we are called in when the kidney fails to think of the disease. So almost 50% of patients with aTPL-HUS have central nervous system findings, and these findings can be variable. It does not mean that they have to present with a stroke, but they can have depression or other neurological disorders. As I said before, the clinical manifestations can be in the kidney, more than 50%, central nervous system, in the blood, very often it's part of the diagnosis, but then also in the cardiovascular system. So we can have aTPL-HUS in the periphery, but also in rare cases in the heart, and we have gastrointestinal. We know the form of gastrointestinal TMA is EHEC-HUS with E. coli infection, but the gastrointestinal circulation can also be involved in aTPL-HUS. And then we have the lung, and we have very rarely the eyes. So you can see that it needs a real doctor. It's a challenge when we have subtle alterations. Now, this is the pathological lesion. And the lesion is thrombotic microangiopathy. We have thrombi in small capillaries. And it is obvious, we'll come to that thrombus formation and Kompleman are not the areas where we all still remember our medical school studies. Normally we have complement and coagulation in year 2 and 3, and then we do learn this, and then we forget about this. So this is, as I said, the mechanisms are complicated. This is what happens. This is normal microcirculation. We have endothelial cell lining, we have white blood cells, and we have the platelets. And TMA is mostly a disease of the endothelium. It's an acute and chronic disease of the endothelium, and the endothelial activation leads then to platelet activation, to leukocyte activation, and then to thrombus formation. Inflammation is involved, and then in the end we have thrombus formation with occlusion, with ischemia, and with organ failure. However, it is important to realize, and I've shown you this rock in the beginning, that the disease does not go through all the time. It's variable. It goes in waves, and sometimes only part of the circulation is involved, as I said before, in some organs but not in others, and then only partially. So whether we have a full-blown picture of inflammation and occlusion and ischemia depends on the severity of the disease, and this is also highly variable. So the clinical presentation is variable, and in order to make a diagnosis, we need thrombocytopenia and the anemia with schistocytes. That's what we normally are called for, and the involvement of an organ, mostly the kidney. But as I said before, all the others can be involved as well. And then we have the diagnosis, the putative diagnosis of this patient has TMA. And you have all had this, patients where you have some degree of anemia or a platelet count of 30,000, and then some organ involvement, and then the question is what to do and how do we get further with establishing the diagnosis. It's very important that for establishing the diagnosis, that's only one part. The other is very early on, define the severity of the disease. Is it organ failure in 1 or 2? Is it partial organ failure? So that we have a definition how the disease proceeds and how fast the disease proceeds in order to make then therapeutic decisions. So these are the investigations which are recommended in the evaluation of a patient with TMA, published in Kidney International. We had a large consensus meeting, KDIGO meeting, about 1.5 years ago, and it has just recently published. This is what we need. We need a sediment. We have to think of an echocardiogram because of possible heart involvement, and this is what we do in cases like that for immunology, because we have other conditions where complement is activated and we can have the same changes in the immunology. We also look for virology because there are viral diseases and they can end up as TMA, and we look for homocysteine and cobalamin C, especially the pediatric nephrologist. It's very important. We need a history. We are talking, when we think of ATTR-HUS, about a genetic disease. I will come to this. So we have to know our other family members involved. And then physical examination, which organs, when you have the suspicion of TMA, the workup sheet should show all this. So in order to make the diagnosis, we do biopsies. We biopsy almost every patient with any changes in kidney function. And sometimes the thrombus is very small. This is a diagnosis from our pathologist for thrombotic microangiopathy, and it's just one thrombus, and you have one thrombus here, so it can be small. Sometimes we have no thrombi, but we have endothelial cell swelling and GBM retraction, and this is also TMA. And sometimes, like in this patient with postpartum ATTR-HUS, we have only subendothelial edema indicating endothelial cell dysfunction. So part of the diagnosis is really how good is your pathologist you collaborate with. How common is TMA in biopsies? As I said, we have done lots of biopsies, 550 biopsies out of roughly 14,000, which we have done over 10 years. So it's not that rare, TMA, but ATTR-HUS is rarer. So we have made a diagnosis of TMA, we have done a biopsy, we know this patient has TMA, and now the question is, what are the causes and the differential diagnosis of TMA? It is important, I think, to realize that we have lots of diseases, and if you have a list like this, this is nice to read, it's from the New England Journal, but it's almost useless in clinical practice. We have to realize that the description of the different entities is a historical one. This understanding of endothelial cell dysfunction is only for 2017 here. The first description, Dr. Moskowitz described a disease which was mostly, but not all of it, neurological with low platelets, and he called this TTP. And then Dr. von Gasser in Zurich, in Switzerland, he described first hemolytic uremic syndrome. And these children all died from kidney disease, but they had also neurological involvement. So we talk about the same disease, but different descriptions. And this is 1983, we are almost in present time. The Lancet EHEC-HUS as another form of TMA. And since when do we know about the cause and the reasons for ATTR-HUS? That's only 1998, that less than 20 years ago, We had this publication from the London group, Dr. Goodchip and Dr. Warwicker, and they were the first 19 years ago to describe that AHHS is genetically determined, at least in some families, and that the complement system is involved. And it was not easy to publish this paper. It took them more than 2 years because nobody believed it at the time. So when we asked what are the causes of TMA, what can we offer? And we have, and this is very important, 2 approaches to that. And I think this is really the most important slide of my talk conceptually, because we are talking about endogenous mechanisms we have to identify, and we are talking about exogenous mechanisms, exogenous factors which stimulate the endothelium and may precipitate the disease. And when we discuss on the ward the patient, we have to differentiate these 2. So let's first talk about primary endogenous TMA. Here we have 4 groups. These are the most important. There are much more than that, but these are the ones, when we do this in the correct order, and clinically it's DIC, which happens on ICUs. And it's important to keep in mind that there are DICs which can be AHHS or TMA. But then we have these 3 groups, TTP, AHHS, and STEC-HUS. So when we have a patient with TMA, we have to rule out which one of these it is, and it's written here, STEC-HUS, AHHS, and TTP. This is the pathophysiology of the disease. STEC-HUS is a disease where the reason for endothelial cell dysfunction is the release of Shiga toxin from bacteria, as you all know. So what we have to do is we have to measure Shiga toxin, and then we can make a diagnosis of EHEC-HUS, and we look for bacteria in the stools, and mostly we do these 2 things at the same time. So within a relatively short amount of time, we can make this diagnosis. TTP, on the other hand, is a very different disease. Here the thrombus formation is because we do not cleave von Willebrand factor on the endothelium. We miss one protease, which is important, and this is ADAM-TS13. This protease cleavage normally is like when you go to the barber, cut your hair because you look orderly, and when you don't do this, then you can form a clot. So we measure ADAM-TS13, and when this is low or not present, then we have a case of TTP. So that's relatively easy. It's much more complicated for AHHS. Because in AHHS we have a disbalance of the complement system, and the disbalance may be due to different molecular defects. So we have to evaluate the complement system, and to evaluate the complement system is not easy. This is an activated complement system. New England Journal, Giuseppe Remuzzi published this a couple of years ago, and I don't want to go even into these different factors. There are more important factors like factor H, which can be easily altered and is very severe. But I think it's very important to keep in mind one crucial fact about the complement system. The complement system consists of factors which are bound to the surface of the endothelium and factors which are circulating in the blood, and they interact. So you can easily see that some of these pathological features, when a molecule here is affected, like thrombomodulin, we have a different picture from a molecule which is affected, which is a circulating factor like factor H. However, and that's another important issue, we all measure complement, but for AHHS we do not have a very good single measurement. We need the patient history, we need components of the complement system, perhaps activity of the complement system in the future, we need genetics, but each one of them is not enough. We bring this all together, and then as excellent doctors we have to generate a diagnosis which does not rest on one single measurement, but is an addition of these different factors. I'll give you an example. When we measure complement factors, we look for C3, C4, different hospitals measure different factors, and this is all very important. However, the screening program provides clues but does not give a definite diagnosis. I have seen patients with severe aTPL-HUS with no significant change in C3, C4, and the other way around. So it gives you a clue if the complement system is involved. Yes, it speaks for aTPL-HUS, but it does not prove the disease. We will have we have functional tests where we can look for the activity of the system. They are not readily available in most hospitals, but also here, these functional tests are important for monitoring patients, but they are not providing a good marker. This is the latest example of a functional test. Here we are mimicking the endothelial cell surface. These are endothelial cells in blue, and then we pipette the serum from patients affected on it, and in green we see the terminal complement factor. But these are not standardized yet. Perhaps we'll have these, but at the moment, important, we do not have these tests. What about genetics? I've put this here a little bit faint because genetics are important, but not for the initial diagnosis. When Warwicker and Goodchip published the disease, it was on chromosome 1, it was one area, and it was factor VIII. But in the same area, we have lots of these regulatory molecules. So to speak, all the family members of the complement system, or most of them, are living together on chromosome 1. And this, at the moment, gives you, each of these dots here, is one mutation in these factors. So this gives you an impression that human genetics is important, but you need actually one human geneticist to understand all this in order to give you a good explanation of that. And to make things worse, these are the genetic drivers. So it's complicated, and the association with a genetic mutation and the phenotype is not 100%. You see here we have pathogenic mutations, likely pathogenic mutations, uncertain significance mutations. We have likely benign or benign mutations. So you really need the human geneticist, but then you have to make a decision as a clinical doctor, is this important or not? And then very importantly, the genotype-phenotype relationship is more complicated. You can have a mutation and no phenotype. And you can have it the other way around. This shows you a family tree who is affected, and here you see the penetrance, and the penetrance is between 40 for factor H and 64 for factor B, which means that's half-half whether you have a phenotype with a genetic alteration. And it's also the other way around. Very importantly, we have a response to treatment without a mutation. So either we don't know these mutations yet, or other systems are involved, but here you can see very nicely that we have patients with aTPL-HUS and they are treated, and without known complement mutation 75%, so that's a high number. And therefore, as I said before, when we make a diagnosis of aTPL-HUS, it's an educated diagnosis which needs a good doctor with all the information I've just provided. And finally, I'll come to the second part, and that's extrinsic mechanisms. What do we have to check when we have a patient with TMA, especially when we have aTPL-HUS? We have to check for all this. Is infection present? Do we have other factors which have caused inflammation? What are medication? We know that cyclosporin, that chemotherapy makes endothelial cell damage and can worsen the situation in a patient where we have a mutation. Malignancy by itself or HIV can lead to endothelial activation. Immune complexes, that's important because in SLE with autoantibodies we can generate activation of the complement system, and this may trigger the disease. In pregnancy, in all pregnant women, we have an increase in complement activity by 300%. But at the same time, we have an increase in the regulatory factors also by 300%, and this balances out in normal pregnancy. But if we have a defect in this regulatory system, then you can imagine high activity of the complement system with a dysregulation, you may have a problem. And in hypertension, the same problem. When we have a severe damage to the endothelial cell surface and a complement abnormality, we may develop aTPL-HUS. So the differentiation between malignant hypertension and aTPL-HUS is not easy. What is very important, always the two go together. However, the relationship between extrinsic and intrinsic may differ. Let me give you an example. Here we have the predisposing factors, the intrinsic factors. If you have a severe mutation, you need only a small trigger from the outside, like a viral infection, and then you have a full-blown picture of aTPL-HUS. On the other hand, if you have an isolated MCP mutation, this is mostly counter-regulated, but if you have a severe challenge to the endothelium, then you get full-blown disease. This is why it's so important to work up the patient and to understand the underlying mechanisms, and always both of them are important. So you can imagine, I don't believe in primary and secondary aTPL-HUS. You have aTPL-HUS, and how these two interact is individually different in different patients. You can also look at this complement activation through all these factors. Normally you have a controlled amplification, so everything is quiet. But when you have a feedback amplification because you miss regulatory factors or you have enhanced activation, then you end up with TMA. So when we look at this, and this is published data from Marina Norris, precipitating event, diarrhea, upper respiratory infections, pregnancy-associated, these are the more frequent conditions. Malignant hypertension in transplant, systemic disease, this is less well known. We have 31% where we could not identify in this study a factor, but I think if you're a good doctor, you decrease this down to 15% when you actually ask the patient or you investigate more thoroughly. So this is the scheme for diagnosis. We went through all this, extrinsic, what we have to ask, intrinsic, what we have to rule out, and then we come to the diagnosis of aTPL-HUS. This brings it all together. We have to recognize TMA, we have to rule out STAC-HUS, we have to document clinical involvement, we evaluate ADAMTS13 activity, and ADAMTS13 activity then led us into plasmapheresis, or how do we treat this. Then we do a kidney biopsy, or we biopsy other organs, and then circulating complement factors, genetics, and then we diagnose aTPL-HUS in the setting of a complement activating condition. Now, once we have done this, we go into therapy. And we have all to do this within 3 to 5 days. We have to hurry. I'll come to this in a moment because it's a life-threatening disease. And this means we always treat the extrinsic mechanism and we treat the intrinsic cause of the disease, but they go together. It's not either or, but always we have to do both. So it's an individualized treatment strategy. We have a patient with severe hypertension. First, the hypertension has to come down, and then we treat Kompleman. Or in pregnancy, we hopefully can bring the baby out, and then if we still have Kompleman problems, we treat with eculizumab. Let me remind you that APPH is a terrible disease, life-threatening. 75% of the patients died from it. And now we have the antibody, eculizumab, which blocks very specifically C5b and blocks the terminal pathway. It's really a blessing. It's a wonderful antibody. It's an astonishingly wonderful antibody which was generated because people, you can imagine, have for a long time tried to make an antibody specific to Kompleman because we know that this is important, but eculizumab works very nicely. So you all know this. It has been on the market. It was successfully used. This is only 4 years ago for the treatment of APPH, but there are 2 important issues I'd like to raise before I stop. One is the immediate effect, and the other is that we still see in all the studies a continuous improvement over time in the patients treated. I've had patients coming off dialysis after 3-6 months of treatment with eculizumab, and we still do not understand this, whether this is regeneration or whether it takes such a long time to bring the complement system really down from damaging mechanisms in the kidney, we don't know. But this means we have an acute effect and we have a long-term effect of treatment. And here you can see this. This is a sample from all the studies. This is the eGFR change over time in these studies. The second issue, which we have just published, the earlier you treat, easy to understand, the better the outcome. This is the mean change in eGFR, and when we started within the first week as compared to later on, we had a better response. So it's like with using steroids in an inflammatory condition, you start as early as possible in order to prevent damage. I think I'd like to finish with 2 cases which we had. We are a large center. We started to be a large center a couple of years ago when we had the EHEC-HUS epidemic in northern Germany. In Hanover, we had 350 patients with TMA, mostly life-threatening disease. And after that, we had more and more referrals. At the moment, we have more than 50 patients with TMA in our outpatient clinic. And I'd like to show you 2 cases. This is a 39-year-old man. In the middle of the week, he has stabbing pain in the lower left leg, weakness. He has high blood pressure and dyspnea. And the dyspnea is becoming more severe. So that's clear for a good doctor. 39 years old, you have a pain in your leg, and you have dyspnea, you think of pulmonary embolism. And yes, the patient has a thrombotic problem. No previous disease, no drugs, which is not true. We know this in the meantime, but at the time we didn't know. On admission, the patient is awake but disorientated, sclera, icteric hepatomegaly. This is the blood pressure, normal ECG. But then the patient develops a stroke very early, first day. And the stroke is severe, and the patient goes not into the renal unit, but onto the stroke unit. The platelets are 120,000. There are schistocytes. The LDH is elevated, but not dramatically. The hemoglobin is a little bit down. So they look for endocarditis because now they find out that he has taken drugs. And then after first day, rising creatinine, acute renal failure, intubation because the patient is so sick from the stroke, from the neurology, and dialysis. Then we do a renal biopsy, which you can see here. And the renal biopsy by our pathologist, the pathologist said, yes, could be TMA, but I'm not 100% sure. In retrospect, we think it was TMA. We re-elevated this. You can see there are at least erythrocyte casts in here. But this is the report which got back to the neurologist. This is what the neurologist saw on MRI. So they saw not a clear-cut lesion for the stroke, but they saw changes which could be vasculitis, but they were not sure, and they were discussing it for a long time. And we were doing the dialysis, but we were not really called in for the discussion. So we went through this, multiple small infarcts, and what do you ask for now? This is not an exam. What they did is actually, they had a kidney biopsy, and they thought it was inconclusive. They did a brain biopsy. They called in the neurosurgeons and said, we have a 39-year-old patient with a stroke. And then we had a biopsy from the brain, and in the brain there was TMA. So then we were called back, and then the patient went on eculizumab, and the patient is now out of bed, fully recovered, still has a peripheral neuropathy because the patient was 4 weeks intubated on the stroke unit, and the GFR is 65. So this tells you how complicated this can be, and I have to admit, even in our hospital, being a large center, these things happen. And the second case, a very traumatic case, a young girl, she's 17 years old. She goes to school, it's Thursday afternoon, and for the last 2 days, she has not felt well, pale, but she has no lymph nodes, pulse is present, she has rales over both lungs, so she gets sick within 2 days. But when you, in retrospect, the mother says, well, she has not been well for the last 4 weeks, she was pale, liver is enlarged, she has retinopathy, she has very high blood pressure, she has anemia, thrombocytopenia, she has respiratory distress, and within the same day, within a couple of hours, remember these rocks in the beginning, she goes on ICU and she is intubated. She has pulmonary bleeding as the first diagnosis. And then overnight she has a serum creatinine going up, she has renal failure, and what do? A renal biopsy, a lung biopsy, a skin biopsy, further laboratory assessments. We have to be quick. It's now really 24 hours. So these are the analyses from the Kompleman system, but we only got them back from Heidelberg 10 days later. But you can clearly see there were not a lot of changes in the Kompleman system, but the patient was severely sick. So pulmonary failure, intubation, bronchoscopy, there is not a lot, but slight bleeding, dialysis, antihypertensive treatment. And this is the kidney biopsy. So that's a classical biopsy, but we biopsied at the same time not only the kidney, here you see dramatic changes in the arteriole, but there was also a lung biopsy done which showed the bleeding, and also that the arteries were affected. This is a thrombus in the lung. And now this patient was treated, another biopsy from the lung. The patient was treated with eculizumab, and this was all stopped. These are days here, within 2 days. Actually, she went home on day number 3. So that's another example of how variable this disease can be. And that we need all this information to be good doctors, to make a rapid diagnosis in these patients, and it needs a lot of skills. And I hope I have provided some of this, and I thank you for your attention, and I think this was the last slide. Thank you very much.